Hello, I'm Mark Painter, CEO of PRS Managed Services. Um, I have been traveling around the country helping physician groups for several years work on improvements to their practice and specifically talking to them about opportunities relative to revenue in the provision of care. And today I want to talk to you a little bit about telehealth and urology. I've been talking about telehealth in urology for probably about 10 years now. Um, and of course, everybody got a boost on telehealth, not necessarily a desired boost, but a boost nonetheless from COVID-19. And now that COVID-19 is over, all the public health emergencies have ended, we've really kind of settled into a pattern, and we've gotten a lot of feedback from the marketplace as to how telehealth works in urology. And I'd certainly like to say that generally speaking, urology services provided through telehealth, when done appropriately, are urology, just done in a different way. So I'm going to go over today a couple of different things, and I have to start with the landscape overall and where we are. So although I think telehealth is here to stay, the reality is that telehealth is here and in a shape that we know of through the end of 2024. There are a number of bills that are in Congress that will most likely make telehealth permanent for the long haul. There may be some tweaks to the rules as they put it in for the long term. But right now, what we know for 2024 is what I'm going to pass on today. So there have been a couple of minor changes from where we sit today in 2023 to what needs to happen in billing and reporting of telehealth services for 2024. We can continue to use audio and visual telehealth in 2024. We're going to continue to use or report services based on the outpatient E&M service codes, new or established. We can still provide video services to patients in the hospital using those evaluation and management codes, but we have to report them a little bit differently in 2024 than we do right now in 2023. So this is probably the biggest change we're facing in 2024. So Medicare has decided that they are going to officially migrate to the new place of service code 10. So 10. The place of service for that we've been using in 23 has been office or place of service 11, and we've been reporting E&M services for patients in their home when they receive those telehealth services using place of service 11 and a modifier 95 to Medicare. Now, some of your private payers do things a little differently, and I'll talk about that in a minute. But Medicare is the biggest player, and the group that, or the rule set that most private payers follow, is the one that I want to focus on first. So they've decided for 2024 that instead of using place of service 11 and modifier 95, that you would simply change the place of service to 10. You will no longer be required to use the modifier 95 for your telehealth services. And telehealth, remember, is audio and visual. You still need to document that the visit contained audio and visual connection for at least a portion of the visit. And then, of course, all the clinically relevant information that you have imparted or dealt with during that particular phone call. The rules relative to a patient and their location remain the same. And I do get this question quite a bit. I know the patient's location is the state in which the license to practice medicine is required. So it's not about where the physician is at this point in time. It is where the patient is located when they receive a telehealth encounter. So you'll need to make sure that that patient is in a location that you are licensed to practice medicine when you're providing telehealth services. And then the overall coding for a audiovisual visit is the same as an inpatient visit. It can be based on medical decision-making under the new rules set forth originally in 2021, or on the time spent dedicated to the E&M service throughout the date of service. So just like an inpatient visit. There are some specific documentation issues that you need to address. So number one, for every visit, you need verbal consent from the patient to be treated via telehealth. That means you need to let them know that they're subject to any deductibles and co-payments. You need to establish the technology that was used and that at least video and audio were used for at least a portion of the visit, even though it may not have been the full visit. And then you need to get from the patient where they're located. So they were in the state of Colorado, where I'm located. So you want to make sure those specifics are clearly documented for each of those encounters. Now, for 2024, Medicare is going to continue to pay for telephone-only visits. Now, telephone-only visits are a little bit different. They have different codes. For Medicare, it's 99441, 99442, or 99443 for physician provided services and for APPs. So a qualified health professional can use those codes. But these codes still require verbal consent. They do not require that you have video, but they do require that you record the amount of time spent on the phone with the patient, because that is the differentiation between the levels of service, the 1 versus the 2 versus the 3. So of course you want to again include all the clinical information that is imparted in during that visit or dealt with during that visit, but you need to record the time on the phone for a telephone only visit in order to properly document and get paid for that. Private payers have bounced around a little bit, but most private payers has settled in to paying for telehealth. And in fact, many of your private payers have invested in and now support their own telehealth entities within their organization. Medicare really is kind of the driver, but we do have variations by state, and what those state requirements are apply to those commercial plans that are governed by the Division of Insurance. You do have some plans that many of you deal with that are ERISA plans, these self-funded programs that are federal, that are not subject to the state rules. So their rules may vary a little bit. So you may have one flavor of United Healthcare that has one set of rules and a different version of United Healthcare for, say, Caterpillar that follows a different set of rules because they're not governed by the state regulations. So you want to make sure you check with each one of your payers and understand what those requirements are. Generally, you're still going to want to let the patient know that they have a copay or deductible that they're responsible for. Some of your payers will allow you to use E&M codes for whether it's audio or audio and visual. They do have different rules relative to place of service 2 or 10. Place of service 2 is the original telehealth services, but with the revision of place of service 10, or that introduction of that place of service 10 a couple of years ago, they refined place of service 2 to telehealth services provided in an approved facility, whereas place of service 10 is for those services provided to the patient when they're outside of an approved facility or a clinical facility. So place of service 10 is going to be appropriate for most of your visits. Some of your payers, your private payers, will still rely on modifiers 93, 95, GQ, or GT, which are the predecessors to 93 and 95. So again, you'll want to check your state rules. You'll want to check your payer rules, and then watch your plan rules relative to telehealth. And some of your private payers have decided not to follow Medicare's guideline and pay at a lower rate for telehealth. But now that Medicare's actually in their final rule for 24 officially shifted their policy to say that in-person and telehealth should be paid at the same level, I think we'll start to see more payers consider that as they move forward, and they'll be required to pay that way under Medicare Advantage plans. The last thing I kind of wanted to address is where telehealth is in urology and where we've seen it successful now that you know kind of the ins and outs of how to report it. So unfortunately with COVID-19, essentially what happened is we had telehealth introduced as a tidal wave. And we had to use telehealth for every type of encounter. And then as we started to open back up, we had some pent-up demand. And quite frankly, physician groups were very busy trying to meet all of that demand. And of course, doing what you all do specifically for your patients and caring for their problems, you went back to work. And a lot of people didn't stop and think, what really should I use telehealth for, and how should I truly execute telehealth? Some groups I know have let telehealth kind of fall off the table, but other groups have kept it on in varying degrees. But we have several groups that have actually really addressed telehealth as a specific vehicle or a way to deal with healthcare. And those groups have been very successful. They've looked at what happens with a telehealth visit, and there are a few things to consider from the financial side of things. So number one, you're saving the patient time and money. The patient doesn't have to drive. They don't have to find parking. They don't have to sit in your office. They don't have to wait for groups to catch up on the schedule. They do still have to pay a copay, so that's kind of equivalent. But they don't have to then wait in the room and deal with all of those issues that extend that particular visit. Instead, with telehealth, they can, from the comfort of their home, connect and receive the information that they need and the instruction and guidance that they need. From the physician side, you are no longer tying up a room. You're not having to change over and clean things. You don't have the same support staff requirements relative to any of your in-office visits. And then the other advantage that we've seen is that telehealth visits, because they are more focused in their interaction, tend to go more quickly. So they're shorter. You can impart the same information without some of the distractions of an in-person visit. So it saves you time. So between time and resources saved with the same amount of reimbursement, there is an advantage here. Now, it's not a complete savings because those folks that do things the right way are still having support staff room their patients. One of the problems with COVID is the physician not only had to be a physician, but also an IT support guru. That is not the best use of time. That doesn't let the physician practice at the top of their license, or quite frankly, the APP practice at the top of their license. So groups that we are seeing that do this well use support staff, either an MA or some clerical administrative support to room the patient, talk to them about their copay requirements, collect their copays, and do the consents before the visit starts so that the physician or the APP can jump on the phone and focus on the healthcare. So it's important to build that infrastructure, but it's also important to remember that the patient's not in the room. Your support staff doesn't need to be in the room. So this is another thing that you can take your staff, maybe use it as both a plus of getting that individual out of the office, but allowing them to work from a different location like home so they can deal with some of their other issues for their lifestyle and still support you and the care and your patients in that process. So there are a lot of things you can do to shuffle things around, but it does need to be treated like a separate line of business. You need specific skills and a specific protocol to run those through. The other thing I would say is that we didn't shift necessarily from telehealth under COVID to telehealth the way it should be done, by leveraging them for appropriate visits. So this is another part of this. Telehealth is appropriate for many circumstances, but really not all, right? So if you have to use it, obviously for some circumstances it's available to you, but in the end, what it really should be targeted towards are those visits for established patients that you are primarily discussing information, imparting information, or checking up on patients and determining whether or not their particular treatment regime is going appropriately. So it's important to look at this from the business aspect of which visits really fit well in telehealth. So I would encourage you to take a look at the business of telehealth as a business line, target it for specific visits that are identified as appropriate, and build the infrastructure that you need to truly support you. It's also good, and what we found is to use telehealth in blocks. So schedule a time period that's really dedicated to telehealth, and that way you can move from telehealth visit to telehealth visit without the interruptions of the day-to-day. You can be much more efficient using telehealth in blocks than you can intermittently using it throughout the day. So as you look at telehealth and you consider telehealth moving forward, I honestly will tell you that it is a service that your patients are expecting. Many of them enjoy it and would prefer it. So it is almost a demand that is added to most of those practices, to most of your practices, to keep up with the demand in telehealth. It frees up some time and focuses things and your people on those things that need to be done in person. So build your business plan, target your visits, build the infrastructure around it, set your schedules up, and then actually start telling your patients which visits are appropriate for telehealth and which are not, instead of letting them drive when they do it. Don't give them the option, give them the direction. Now, obviously, if they can't, you still have the option to bring them in the office, but in the end, you want to actually drive telehealth as an accepted way to treat your patients in urology. Thank you very much. Hope you've found this information valuable, and you can contact me with any questions. I've provided my email, markp@prsdata.com. Thank you very much.